Hello, you're watching the PA Chat. For Positively Aware, I'm Rick Guasco. People with HIV are living longer than ever, but many are also experiencing challenges associated with aging, such as inflammation and cognitive decline. Now, new research suggests that a class of drugs that are already being used for treating the flu could one day help address those concerns. In a study published in the journal Med, researchers identified a biological pathway that may contribute to accelerated aging and cognitive impairment in people with HIV. Researchers found that blocking that pathway reduced inflammation and memory deficits in animal models. Here to discuss those findings is Dr. Mohamed Abdel Mohsen, Associate Professor of Infectious Diseases at Northwestern University's Feinberg School of Medicine here in Chicago, and one of the study's lead authors. Dr. Abdel Mohsen, thank you for joining me. Hello. So just tell me a little bit about yourself and your work.
So my name is Mohamed Abdel Mohsen. I'm an associate professor here at Northwestern University. And in our lab, we study glycans, sugars, structure, sugar species called glycans that exist in all proteins in our bodies. And we study how they impact immunology in people living with HIV and how that impact their aging with HIV.
What role do sugars and glycans play in HIV and in HIV health?
Yeah, so that is like, for an example, part of this paper we just published where the main goal was to answer the question or to understand why some people living with HIV, despite being on effective antiretroviral therapy, is still experiencing cognitive impairments, like problems with thinking, problems with memory, again, despite being on therapy. And we know from our previous studies that as we're getting older, all of us living with HIV, men and women, we lose systemically protective sugar species called glycan that is decorating our proteins. And they are there, part of their job is to protect our bodies from excessive inflammation. So again, as we're getting older, all of us, we systemically lose those protective glycans. And it's interesting because it's a very systemic, that is, we can use these glycans rate of degradation as a biomarker for the biological age of a body. So you can take a sample, you can measure a glycan, and if it's, it should be degraded by this percentage, so this person is that age. Or if it's degraded faster, this person is having an accelerated aging, and vice versa. And it differs dramatically between men and women. So usually men degrade these protective glycans at a very steady pace from the age of 18 to 100. While women have this very interesting biphasic degradation. It starts degrading this glycan very slowly at the beginning, much slower than men, until certain point, which is menopause. And then at menopause, there is a very rapid acceleration in the degradation of this protective glycan to reach the same level of men or surpass it. So a few years ago, we asked the question, do people living with HIV, despite being on antiretroviral therapy, exhibit an acceleration in the degradation of this protective glycans? Because we know people living with HIV sometimes exhibit like higher rate of aging-associated diseases that sometimes happen at higher rate and maybe at younger age than their HIV-negative counterparts. And indeed, that's what we found. We published this paper a couple of years ago using like a very large number of samples from the maximized cohorts, analyzing samples from men and women separately, living with HIV and not living with HIV. And we indeed found that as people living with HIV, despite being on long-term antiretroviral therapy and very high CD4 counts, are having a more degradation of these protective glycan than what would normally be for their age strata. Like they should be having that level of degradation. No, they have more degradation. And again, as I mentioned, these glycans are there to protect our body from excessive inflammation. So when they degrade it faster, you're getting more inflammation. But in that paper, we haven't linked that necessarily to a particular aging-associated disease. We have some ideas in there in cancer and cardiovascular diseases. But in this paper we're discussing today, we want to extend this to a particular comorbidities that is, happen, as far as I know, at least in a quarter of people living with HIV despite being on therapy, which is having some sort of cognitive impairments, like maybe mild, but it exists and it impacts day-to-day life. And indeed, we found that is using two cohort of sample from ACTG of people living with HIV with and without cognitive impairments. That is, the people living with HIV, men and women who have cognitive impairments, have more glycemic degradation than the people living with HIV without cognitive impairments. And this was more pronounced in women. And so again, coming back to what I said, that is, women experience this very dramatic changes in their glycan more than men, and this is linked to menopause and estrogen level. But in this paper, we want to take this to a next level. Is that just a biomarker? Is this just like something correlate with cognitive impairments and inflammation? Or this is kind of maybe like causing it, or at least contribute to it? And we did some in vitro experiment, and indeed, we found that is these glycans being degraded by an enzyme that's removing them. Like, for an example, there is this protective sugar in our proteins called sialic acid. Sialic acid is normally degraded by this enzyme called sialidase, enzyme that will remove sialic acid. And this sialidase will make the immune system more inflamed because it will remove this protective sugar. Mm-hmm. So we thought, can we prevent this from happening? And it so happened that is influenza do have a similar enzyme called also sialidase, but the viral version of it. Humans do have their own sialidase too. And that is why it's pretty common that is to treat influenza, you will try to inhibit this sialidase, the viral sialidase. And that is what many viral drug is based on, to try to prevent the viral sialidase. But some of them also extend to also prevent human sialidase. So we tried these in animal model. It's just as you know, it's a proof of concept. Right. That is, if we can preserve these glycan and preventing them from being degraded, we can preserve their anti-inflammatory properties. And we expected some effect, but I was actually honestly surprised myself when we tested this in animal model. We did see a larger effect than what I expected. In a humanized mice, we infected with HIV. We found that these inhibitors can prevent inflammation, could prevent aging-related changes, like people measure accelerated biological aging using something called epigenetic clocks of aging. When you look at the modification for your DNA, which change as you're getting older, the mice do experience similar things when you infect them with HIV. This inhibitor prevented that. But even more importantly, this inhibitor prevented memory loss in animal model, about 60-70% of the memory loss. But again, as you mentioned, this is more of a proof of concept. That is, if we can preserve these glycans and preserve their anti-inflammatory properties, we can make some changes, at least in animal model. Obviously, we currently working in two angles. One, we have some preliminary data that is this glycemic degradation might happen even before the onset of comorbidities in people living with HIV, not only neurological impairments, but cancer and cardiovascular disease. So we want to know if that's true or not, because if it's true, it might serve as a very interesting biomarker, which could be very, very important to take a simple blood sample from a person living with HIV, and maybe you can tell them they are at a higher or lower risk of developing these aging-associated diseases. Because again, we find this the glycans is being degraded faster, like earlier, before even the disease happened. But even more importantly, we now try to think okay, we now have this proof of concept that is using those sialidase inhibitor mainly developed for flu. But if the idea is correct, can we develop something better, more specific, that can preserve these glycan from being degraded? Now we know that they are actually not just a biomarker, they actually may be contributing to this phenotype. And by preserving them, we might, or losing them might be contributing to the phenotype. So by preserving them, we can hopefully reverse or prevent this phenotype. But that's something we are working on now, to try to identify a molecule that can do the job of the flu drug better. Or maybe, I don't know if the flu drug will work or not, because obviously the flu drug is approved for a particular condition, a particular purpose, and it has been tested for this condition and this purpose. and dosed this way, the side effect is determined in this way. I don't know. We don't know, obviously, if they can repurpose or not for cognitive impairments in people living with HIV. That does need a lot of study, preclinical and clinical, to know the optimal doses, the safe dose, the effective dose, and it could be possibly that it's totally different drug will be better, because again, we use them just to prove a concept, but what we will hopefully advance in the future might be something more developed or designed for this particular condition in this particular population, which is totally not something that is these flu drugs are approved for.
But so if I can ask then, what's to stop somebody, or why shouldn't someone go to the drugstore and just buy an armload full of flu medication?
Like two reasons, actually. First, as I mentioned, they are not tested for this condition in human. We have tested in animal under a specific condition. There is no proof that is any of this drug for long term could be safe or effective for neurological impairments in people. That can and should be tested, but until then, people should not. Second, we did use two flu drugs. One of them is you can go and get it probably from the pharmacy, called Tamiflu. As far as I know, the other one is not yet approved. And I don't know if one of them will even work by itself. We don't know. We used it in this paper based on our data in the lab. We found that is we need these two together, and one of them is not even, you cannot get. So the other one, even if you can get, we don't know, we don't even have an animal proof that is it can work by itself. But either way, even if we have the animal proof that is both of them can work, people should not take drug that was not approved for a particular condition, because the approval for a particular condition will mean that is the doses was tested carefully, the duration was tested carefully, and other aspect pharmacologically was tested carefully in this population for this purpose, which is again something not happened. What our paper was mainly focusing at is to show that this is a proof of concept that is totally novel mechanism, that is nobody have even thought that might be contributing to the aging associated diseases in people living with HIV, which is accelerated loss of protective glycans, which is normally happening with age, but apparently accelerated in people living with HIV. We don't know why it's accelerated in people living with HIV, which could, there is multifactorial reason for that, including maybe the initial infection before ART start, maybe residual virus, production or so. Maybe ART itself, we don't know what it is, but it's something it's very important. It's not something unique to people living with HIV. We see that in other population that is living with a chronic condition.
Okay.
That is, they also have an acceleration in the degradation of these protective glycans. So it's not something unique in people living with HIV, but here in this study, we did see it in people living with HIV for the first time, and found that is interfering with this mechanism could have a beneficial effect, but this interference in the future not necessarily will be done therapeutically using these two drugs we used in animal. It might be in a totally different drugs, or maybe it is the same drugs, but maybe different dose, maybe different schematic of treatment. That is something will take probably years to be tested and finalized.
Okay, so with the proof of concept, do you have a definitive answer that yes, this what you know for now, and we're ready for the next step? And if so, where do you go from here with the work? What's next?
Yeah. I did expect if we use those drugs to show some effect, but I was personally surprised with how reproducible and strong the effect are in animal models, at least in the mice. And again, there is no animal model recapitulate human; they are models.
Right.
But that if we believe the animal model data, this was quite strong and reproducible and we tested this in male mice, female mice, In the paper, even we showed each one of those experiments separately because we did 4 different experiments in animal, and each one of them showed the exact same data exactly. Mm-hmm. So we do believe, as far as we know, this is a true signal that is we are seeing, and that's why we are our next step, as I mentioned. We can measure that glycan easy using like a finger, like in a blood drop, and we're using this to predict the biological age of a body. And we do that already. But the question is, can this biological age, based on glycan degradation, predict health span? Okay, that's where it will be important. You can measure biological age using different methods, but if it doesn't tell you something useful clinically in the future, what is the point? So that's what we're working on now, to use longitudinal samples from people living with HIV, that sample collected before the onset of aging-related disease, and we know which one of them got aging-related conditions or not, like cardiovascular disease, neurological impairments, cancer, and we will see, can we predict these clinical and subclinical events before they happen. So that's one direction we're working on. The other direction is, can we identify other molecule, safe molecule, maybe natural molecule that can do the same effect of preventing the degradation of this glycan and preserving their anti-inflammatory? And do they work better than even these 2 flu drugs that is we tested in animal model? And if they do, that's what we will prefer. If they don't, okay, these 2 drugs we did test in the animal model and they work it. Can they be safe in human to be tested in? Because testing them for flu, you're giving them for like a week or 10 days. It's totally different dynamic. Can they be used safely and effectively in human with cognitive impairments? And that is obviously need collaboration with clinician, with pharmacologists, with whatnot. But those are the 2 angles we are working on, following up on these papers.
Sure. And if you're talking about some sort of treatment, then that wouldn't be just a one and done thing. This would have to be ongoing medication as well. I mean, that just like with my HIV.
Exactly, because we also, like as I mentioned to you, these drugs preventing the glycan degrading enzyme, but they do not solve the problem of why even there is a glycan degrading enzyme. And we know these glycan degrading enzyme coming from these cells called senescent cells. So some cells in the body, as we're getting older, they're getting into this like quote zombie phase. They are not alive and they are not dead. And they start to producing molecules that could be beneficial in the normal condition to make sure that there is a good type of inflammation. But at certain point, this inflammation counteract and they become detrimental. So maybe even a better idea, instead of like preventing the activity of this enzyme, to remove those cells that is producing it. So that's why I'm saying this is more mechanistic, to try to understand why people living with HIV. And we do have some ideas. So maybe in the future we can come up with something even better than just try to treat the symptoms, or even try to prevent a middle step in the equation. And maybe we can try to go back to the actual source of all of these problems. And maybe part of that is these cells called senescent cells. So that's another angle we're working on. Can we actually even go back to see what is this cell that is producing this enzyme that is removing this protective glycan? And if we can identify these cells, why they are increased in people living with HIV despite being on therapy. But regardless of the reason, can we remove them? Can we find a way to get them out of the body? And will that actually be kind of like a better source, a better solution? But if that is not possible, maybe it will be hard, because actually senescent cells is kind of like very similar to HIV resistant cells. They are very hard to find, very hard to identify, but they are very important. But if we cannot do that, at least we can prevent this enzyme from degrading our glycan, our protective glycans. Maybe some people even outside of the HIV field try, okay, let the glycan being degraded, I will give you another glycan, like, supplemental glycan.
Okay.
So we're testing this as well. But all of this stuff will need an extremely, careful examination for any of those. Like if we at the end focus on one or two, we need, obviously, as I said, working with clinician, working with pharmacological people and all of this stuff to test efficacy and testing. But this paper was important to identify the mechanism. This is an important mechanism, and it's not just a correlation. It's actually something we can interfere with using tools we have, but it's not designed for that. Yeah. Now the next step, now we know that, let's actually find the best way.
Okay.
Whether the best way with these two drugs, but we test them in human, another totally different drug to do the same effect, or even something to try to go to the root of the problem and fix it from the root, which will be obviously better, but will be harder.
Okay. So have you gone as far as you can with the animal model?
Yeah.
Okay.
With the animal model, we went as far as we can. No, we did not actually, because there is many different conditions you can try in the animal model that we will also need to try. Like you want the mice be treated on art early versus late. You want male, female, which we did. We want old, young. You want both menopause in the female versus young menopause. We want to try to capture as much as possible different demographic and clinical factors that exist in people living with HIV to try to see if this is effective in a one particular condition or it's a more generalizable. And that will be also another important thing into moving this in the future to the clinic, because maybe that is not working for everyone. Maybe it is beneficial for subgroup and detrimental for another group.
Okay.
So all of this stuff need to be tested also in the preclinical animal model, but obviously that needs funding and need regulatory and stuff. But that's another thing we still need to do, but we will prefer to do this using the one or two candidate drug that is we will eventually think that is what we will want to push forward to the clinic in the future, which is something we are still not even there yet because we just published this paper, but we're already trying to find what we will think most likely will move it to the clinic. But when we do that, we want to try different variation of the animal model, like even animal model with and without drug abuse, because we know that exists and that does correlate with neurological impairment. So what if these drugs only work if you don't have drugs, like drug of abuse in your system? And if there is a drug of abuse in your system, maybe they will be detrimental and they will cause toxicity. We need to know that before we also moving forward. So all of those different studies need to be done. Now, again, this paper just sets a very basic foundation. This is a mechanism that we didn't know for, which is the degradation of protective glycan. This might be contributing to this detrimental phenotype of accelerated aging. We need to know how to interfere with it, but this how encompasses a lot of questions. Not only what is the drug, what is the dose, what is the schematic, what is the best population of people demographically and clinically. So that's another stuff we are working on as well.
Okay. Do you have a timeline, an idea as to, how many years are we talking about before we see something?
A lot of this will usually, and as you know, always depends on availability of funding and regulation and stuff. So it's very hard to predict that. We, as you imagine, we always take this data, put all of these ideas I mentioned to you now into grant application. We're trying to get funds to do them. So it all depends on the availability of that. But the good thing from the paper, we have all of the tools. Like we can, as I mentioned, take a drop of blood and measure the glycan, like the glycan degradation of aging, or what people call glycan age. Yeah. We can do that. Like, whether we will have access to the samples we want to have access to, which is, as I mentioned, longitudinal sample from people living with HIV before even they get clinical and subclinical, and how many samples you need to do in order to call something a biomarker, which is you need sometimes thousands of samples to be confident this is something you can measure. Obviously require funds and time. It's like, identifying a molecule and doing work with them, again, require time and money. So it's hard to predict how long this will take, but probably in the years, level at least.
What can you say to people living with HIV right now who might be thinking about, do they have the beginnings of cognitive dysfunction, or who might already be worried about it? What can you tell them?
I would say that is, you have to discuss that with their doctors and follow the current guidelines, because the current guidelines are the one that is, tested and vented, and they are the one that is have a proven scientific reasoning for that they can help. But on the same time, that is, there is a lot of people in the scientific community trying to do a lot of work to understand the reasoning why this is happening and how we can interfere with that. And hopefully with more work in the future, there will be something that can help better than what we have now. But for now, the best strategy is to follow what is the protocols and the guideline that is they can get from their physicians.
Okay. And maybe even before they talk with their doctors, or as they're talking with their doctors, what should they be looking for in themselves if they have any concerns?
Like, I'm not sure, because I'm not a physician myself, so I'm not sure I can identify what is the like particular signs of people living with HIV that is might have more or less severe cognitive impairment. So
Okay.
I'm probably not the best person to comment on that.
That's fine. Can you speak to what the difference is in cognitive impairment and in aging overall between somebody with HIV and somebody who doesn't have HIV?
Yeah, we know in average people living with HIV get aging associated comorbidities at more frequency and younger age. But at least from the glycan point of view, I think what we see in people living with HIV is not unique to people living with HIV. It happens in all of us. As I said, every single one of us living with HIV or not, men and women having this glycan degraded.
Yeah.
In people who are living with a chronic condition of any kind, we often see this glycan being degraded faster. So I do think also there is an implication this work might expand beyond HIV, but obviously it's much more important in people living with HIV because they have an acceleration in this degradation. So the goal is to get them back into the normal pace of the degradation. And who knows, maybe them and other people not living with HIV can even slow this pace in order to preserve their health span by preventing inflammation. But I do think this is not, it happens in many other conditions we saw.
Now, you mentioned health span. What's the difference, by your thinking, between health span and lifespan?
And that is actually a very important question, and it's very relevant to people living with HIV, because the antiretroviral therapy do preserve the lifespan significantly, but there are some studies showing at least like that people living with HIV might be experiencing a comorbidity 10 to 15 years younger than people living without HIV, which is exactly what is health span. So the lifespan is how many years you are living, but the health span is how many years of these years you are living, that is, you live without an aging associated comorbidities. And this is very important to get it as extended as possible. So it doesn't really necessarily like you live longer, but you live healthier. You live without comorbidities. And a person could live to their 80s or 90s, but maybe 50 years of those you are living with a chronic condition that is impacting your life quality. And I think that is what we do see to some degree with people living with HIV. Again, to some extent, the antiretroviral therapy extended the lifespan. So now you can live almost normal to the people living without HIV. But a lot of those years you are living with a chronic condition related or unrelated to HIV, cardiovascular, neurological impairment. So we want this to be gone. So you might live the same amount of years, but you live this amount of years in a total health. Even if you don't cure HIV, if you don't get the virus out, but you live as healthy as possible. And this is, again, a goal for all of us, living with HIV or not. Goal in general for the longevity or health span field is to live as many years as healthy as possible. This has become even more important in people living with HIV because this number of years even shrank.
Right.
So we wanted to go back to normal, and then hopefully we can take this normal in both people living with HIV or not and make it even more long. I think that will be great. Again, regardless of how many years you live, you want to live healthy.
Right. In fact, in listening to you, I'm thinking about long-term survivors and that span of healthy living and decades of living with the virus.
Yeah.
How is it different for people who were born with HIV?
Yeah, that's another important question. We don't know. We don't know how being born with HIV, being exposed to HIV, but HIV negative, having the HIV at young age, all of those are different questions. We don't know, and we need to study it to understand this more. But I don't think that is known. Like we don't know for like we did measure the glycan degradation in multiple population, but we haven't had the chance to study those population. And I think that will be important because I don't think, again, it will be like one answer fit it all. We will need to understand the different demographic and clinical factor in order to make sure how to tailor a way that is allows this super health span. And the cool thing is, if it happened in nature, I think it means it can happen. And we know there are some people in general, not living with HIV, who are called super ager, who are people in their late age, but they are having the cognitive function of a young person. What is even more cool, is there is a super ager with HIV. People living with HIV, and despite being living with HIV, which we know accelerate aging, they actually have the super aging phenotype. So we know this has happened. This exists in nature. That is, there are some people who have an amazing health span. So if that happened, I think we can learn from that to mimic it in the rest of people living with HIV. And honestly, the outside even of people living with HIV, because the super ager with HIV phenotype is desirable even outside of HIV, because everyone wants to have the health span. So I think the fact that this exists in nature, telling us that is we just need to study it carefully to know what makes those super ager, what higher in them that is protective, what prevent it from being degraded, like this glycan from them. And that is, we know, okay, this is the mechanism we want to work on. And those people exist, and we also study samples from them as we speak.
What got you interested in this field, and why do you do this work?
Yeah, I think it's we in our lab we do a lot of work related to HIV, but I think that is we can, and that's why I'm excited about this work. We can make a difference. Like we can actually help. We can, even if we don't cure HIV, if we don't remove the virus, but we can make the people living better, living healthier. And I think again, the work we are doing also we as actually common from the start of the pandemic of HIV, everything we do in HIV can be expanded and we can use it to teach other field, other stuff. I do think what we do can be expanded to even outside of the HIV, and we can help other people. So I think that this idea of like you can make a difference in people's life is very important and can motivate you so much to do this work. And I think we can do that because again, people living with HIV are experiencing this phenotype, and if we fix it, we can make an impact in their life. So this is again motivational thing that is may make us continue doing what we are doing.
And then last question. One of the reasons why I wanted to talk with you was because, well, of the headline. What would you want to say to people, especially people living with HIV? What should they be thinking about when they hear these sensational headlines in the news, or they see a sensational post in social media about a breakthrough or a cure that's just around the corner? What should they be thinking about when they hear stuff like that?
Yeah, I do think, as I mentioned, the people need to focus in two things actually: listening to their physicians and following the guidelines that exist now. While they are hearing all of this news, they know that there is a lot of important research that is being done in order to hopefully help, but that is something in the future. And yeah, that is mainly saying.
Dr. Mohamed Abdel Mohsen, thank you for talking with me today, and thank you for watching this video. To learn more about the study and its implications, go to positivelyaware.com. And if you like this video, be sure to tell someone. Like us and subscribe to Positively Aware's YouTube channel and follow us on social media. For the PA Chat and for Positively Aware, I'm Rick Guasco. Thank you.